Professor of Public Health at the University of California, Merced, and core lead for UC Merced's Nicotine and Cannabis Policy Center, what we call the NCPC. We're so excited to have you all here today to learn a little bit about our center and then about what's happening in California's San Joaquin Valley around tobacco, vaping, and COVID-19. So I'm just going to take a few minutes to talk a little bit about the center, and then I will turn things over to the panel. So NCPC was established years ago with support from the Tobacco-Related Research Program to address tobacco policy disparities in California's San Joaquin Valley. And the community core that I lead was established to really strengthen collaborations with local community-based organizations such as Healthy House within a Match Coalition and the California Health Collaborative, among others, and with state and national organizations such as the California Youth Advocacy Network and the American Heart Association, who's co-sponsoring today's webinar. And we work in partnership with these organizations to communicate the importance of and reasons for conducting research in our region, and to help present research findings in an understandable and engaging way. So our primary aims of the community core are really about network building. We came together in order to build a network of community-based organizations, those that have more experience with tobacco policy and advocacy, and those that have more entrenched local ties, but perhaps less policy experience. And we've brought those together, those organizations together, and developed structured mentorship opportunities in order to build local community-based organization tobacco policy expertise. And in addition to this, we're working with these organizations to develop expertise together with San Joaquin Valley youth to affect policy change, because we really see youth as the change agents of the future, and we want to make sure that they have the support that they need to move things forward. So in the first 2 years of the center, we've largely served as a convening role. We've brought together the expertise that already exists in our region in workshops to share information, build policy relevant skills, and facilitate communications between community members and their elected representatives. Until now, all of these activities have happened in person. So this is our first foray into online convening. We're really excited to have so many of you present to share this experience with us. So today we're going to hear from experts about the latest research that's available on how the COVID-19 pandemic is impacting those who use tobacco or who engage in vaping. Our particular focus, as I mentioned, because of the focus of our center, is on California's San Joaquin Valley. So now I'd like to introduce our panel. I'd first like to introduce Norval Hickman, who is Program Officer for the Tobacco-Related Disease Research Program at the University of California Office of the President. And Norval is going to chair our panel today. And joining him are Garcia-Ojeda, who is Associate Teaching Professor of Biology at the University of California, Merced. And joining him are Gil Lopez, who's an assistant professor, a newly minted assistant professor at Arizona State University in the School of Transborder Studies, who's doing really interesting and important work in the Valley. And Anna Epperson, who we're very excited to welcome as a new assistant professor of health psychology at UC Merced this year. And you can learn more about them at the NCPC website, as well as by reading the flyer that we sent out to you with the original. So now I'd like to turn things over to Dr. Hickman to get us started with today's presentations, but I just want to welcome you all and thank you for coming.
All right, thank you, Nancy. Hopefully everyone can hear me okay, and welcome everyone. Good afternoon. I'm really looking forward to today's conversation and hearing from all our panelists, in addition to hearing from those of you who can stay on after the formal talks. Our plan today is to have each of our speakers present for about 5 to 10 minutes and then open it up for questions. We've received some questions in advance. Thank you for sending those. We'll go through them, or as many as we can. And you can also submit questions using the chat function in Zoom. We will hold questions until the end of the speaker section, and we don't want to take away from the rich discussion we're going to have in breakout sessions after that. So just for folks who do want to stay, who have time this afternoon, you will have an opportunity to join a small group discussion and really tell us in terms of what you're seeing and experiencing on the ground. What successes you may be getting in some of the work you're doing in the community. Also, what challenges you're facing or you see coming down the pike, and where more research and resources are needed. Please don't hold back when we get to that portion of this program. We will break out into those small groups, and then we'll reconvene for a report out. So keep in mind that there will be someone collecting some of this information. Also, in addition to this being recorded, people will be taking notes. Looks like I got muted. Okay, looks like I'm unmuted. All right. So that's overview for our next couple of hours. Let's go ahead and get into it. Okay. And let's see how I advance these slides. There we go. Looks like I can now. Great. So my hopefully brief talk is going to focus on community engagement at the intersection of smoking, vaping, and COVID. And to be honest, I'm going to spend quite a bit of time going into the pandemic and where we are now. Really want to highlight from the New York Times the recent alarming increase in identified COVID-19 cases across the country. This chart represents over the past 2 weeks, yellow and orange indicating an increase in rising COVID cases. These are new cases, and this is more of a rate, an increase. So these are things to be concerned of, not just in California, but as you can see across the nation. In terms of also from that same New York Times report, using some data from this Saturday, we're looking, there have been at least over 5 million diagnostic tests performed. We know that some areas don't have enough testing available. In terms of identified positive cases, we're looking at about a little over 300,000. And I'm sad probably to say by now over 7,000 deaths nationwide. And this is looking like it's going to continue, at least might even escalate depending on how things progress. Nationwide, I'm going to get into disparities because that is an area of funding that I manage in terms of the grants that come through TRDRP. And this is an article I recommend you look at from the New York Times based on CDC data as of May 28th this year. And we're seeing and continuing to see Black and Latino Americans having the disproportionate number of new cases, and this is per 10,000 people. And this is what we're hearing in the news. This report is good in detailing some of those disparities. And I just highlight to bring up on this slide that African Americans in particular are bearing the brunt of 2 to 4 times more cases than whites, and this is represented in the eastern half of the US. The West Coast, we do have pockets where African Americans have very high rates, but they did not show up in this map, and this is data as of May 28th. I think more current data would show that. And just to move to the California story, in terms of our state, where we have flattened that curve for a while, and then now we're seeing that curve increase. I wanted to put this slide up from our Department of Public Health, again, data from this weekend. And as you can see, in terms of positive cases, looking for Asians, about 6%, and all Asian ethnic groups represent about 15% of the California population. African Americans, from this report, about 4.4% of positive cases, and Latinos bearing a huge disproportionate burden of new cases on the West Coast, in particular California, as you see there, over 50% of positive cases, while representing about 39% of our state's population. And then you can see the numbers for whites, which are the cases are lower than the representation statewide. Moving on to this slide, which I think, oops, just lost my ability to forward. Oh, there we go. All right, in terms of the deaths, which are critically important, you see the disparities, the disparities related story kind of takes a different form here, where we have Asians actually a higher proportion of deaths there. This is of total deaths of these estimates, representing about 14%. So now we're closer to the representation statewide. And African Americans higher, more deaths than representation, and still also among Latinos, much more deaths we're seeing than in terms of if you look at all Latinos together, ethnic groups statewide. And whites, that number does go up too. So it's good to look at both incidents or cases and deaths because it tells some different stories here. I think in particular for this talk, we really want to highlight the concerning increase in incidents among in the Central Valley counties. And people on this call probably know the demographic groups that are living in the Central Valley. But I think recently, back in April, when I pulled up data like this among new cases, we didn't see Fresno and Kern County on there, and now we do, and Riverside as well. And the concern is this will continue, and we might even get pockets within the Central Valley where we're looking at a worse situation in terms of COVID. Some factors, just briefly, there are more factors that increase risk for COVID. Just want to highlight some that we know, some that we might not think about. Older age, diabetes, other health issues, compromised health issues, obesity, if you have COPD, asthma, other respiratory issues, as well as structurally, poverty, associated stress factors from that. Immigration status can play a role. Lower access to quality, non-discriminatory healthcare and testing also plays a very pivotal role in even identifying where the hotspots are and where things are escalating. We have to consider that a lot of our communities of color are living in multi-generational households. It can be exceptionally challenging to social distance in those households and settings. And a lot of folks, especially represented by Latino ethnic groups in the state, are essential workers, are considered that, and so are African Americans. And not only is the income from their work needed to live, but also that we have a societal need for the critical services that people are providing that are considered essential workers. In terms of smoking and vaping, I'm not going to do this justice in one slide, but folks should know, and many of you are aware, that tobacco smoke has a lot of cancer-causing chemicals. It affects almost every part of your body. Secondhand smoke disperses and affects others. When we look at e-cigarettes or vapes, oh, good. We see that there are fine and ultrafine particles that are deposited all throughout the lung and respiratory system. There are cancer-causing chemicals, not as many as in tobacco smoke. We have heavy metals and other things to worry about with e-cigarettes. The things that are on the right can pertain to both inflammation, reduced lung function, breathing issues, narrowing of airway, excess mucus, respiratory irritation, illness. All of these set up a ripe situation for COVID to not just get COVID-19, but to have more severe cases. And UCSF study just came out, Journal of, I think, of Adolescent Health, that marked that young people 18 to 24 who smoke or vape have a 1 out of 3 times risk of a severe case of COVID versus non-smoking young people have I think a 1 out of 16th chance of a severe reaction to COVID. So it does, the lung environment is very delicate, and lung health is very important, and part of what people don't understand is that environment and how susceptible you are depending on what other environmental exposures your lungs are subject to. Okay, and I think I have one more slide. I got to figure out how to advance it. Something changed here. There we go. Community engagement tips. So just want to touch on that a little bit as you're working in communities, and maybe to kind of foster some just general ideas when we get into our small group discussions later, is we always, when we're engaging with the community, we want to recognize the historical oppression and discrimination that people have experienced, individuals and in groups, the environmental context that they bring, Try to grow your ideas out of community concerns and interests, and learn to frame your issues and communication according to the values and the language that is used in the community. Share your power, regardless of where you are situated in your organization or institution, and decision-making authority. That goes a long way to building a good alliance and trust in communities. Identify and build off of community assets. Communities have assets and strengths, and ensure community has resources to engage in intended behaviors. If you're promoting that, be ready to provide those resources or link with navigators that can do that. So this is going to conclude my little framing session. My email is there through NCPC. You can find me. I'm online. You can, if you have questions or to further this discussion. I want to move on, and once I get my screen, thank you. To introduce, or already introduced, to turn this talk over to Dr. Garcia-Ojeda, who is going to enlighten us. And I lost my slide here. Where is it? Yes, on how smoking and vaping might exacerbate COVID-19 progression and disease. This is critical, and looking forward to hearing his talk. Let's take it over.
Yeah, sorry, I guess I was muted. So my name is Marcos Garcia-Ojeda, and I'm a professor of biology at the University of California, Merced. And I would like to talk to you about some of the information that I found on how smoking may exacerbate COVID-19 disease. So I think here we go. So I'll start my presentation to give you a little bit of objectives that I would like you to get out when we finish our conversation. I want to introduce you about the general architecture of the lungs and the lung epithelium. Being a biologist, that's what I'm going to be looking to concentrate upon. I want to give you some information about how the viruses that causes COVID-19, the SARS-CoV-2 virus, infect cells. And I want to then bring your attention to some of the papers that have come out about how cigarette smoke may enhance COVID-19 disease. So I'll start by just giving you an overview of the anatomy of the respiratory system, which we can divide into two major regions: the upper respiratory tract, that includes the area of the nose, the mouth, the sinuses, and the throat, as well as the areas of the lower respiratory tract that has the trachea and the lungs can be subdivided into the bronchia, the bronchioles, and the alveoli. So now, when we think about a virus, the virus is infecting cells. So I want to give you a little introduction to some of those cells that are also being infected by the virus. So we have three general regions that we can think about it in the lung tissue. One region over here, I think you can probably see my mouse moving. That region is the thick, the large epithelial airway, and it has a layer of epithelium. As you can appreciate from the picture, it has some cilia. Those little hairs, they move to help move the mucus that is generated in the lower part of the lung up the trachea until we can swallow that mucus away. When we move deeper into the lung, we are now into the small earthway epithelium, and that has a very different kind of epithelium. The cells are more tube-like, and you have this very cool little club cells that help secrete mucus. And the deepest part of the lung is the respiratory area, where we have the gas exchange. Here in the alveoli, the little sacs of air that help us exchange gas, oxygen can come in from air into the blood system, and carbon dioxide can get out of the blood system into the alveoli so we can breathe it out. An interesting thing about this virus is that it can infect the epithelium of the large airway, the small airway, as well as these type 2 alveolar cells that are found in the respiratory area of the alveoli. So how is this virus doing this infection? So we have known that coronaviruses use the angiotensin 1 converting enzyme 2 or ACE2 protein as a way to enter the cell. That protein, his function is not to really have a virus use it as a port of entry. It is actually part of a mechanism to break down the molecule angiotensin. So it's the second molecule that is the second protein that breaks down angiotensin. So angiotensin is break down by ACE into angiotensin 2. Angiotensin 2 can either bind to this receptor ATR1 to do a function, or it could be further broken down by ACE2 into ANG17, and it binds a different receptor, this MARS-R, to do a different function. Well, what evolutionarily has happened is, and with many viruses, is that the coronaviruses have used that ACE2 receptor as a way to get inside the cells and hijack it, as shown over here in the left-hand side of this image. So this ACE2 protein is found in many of the tissues of the lung, as well as other tissues like in the kidney and the liver, for example. So interestingly, and I'm going to show you some data about that now, here again, just to remind you, we have the different areas of the epithelium. A recent paper by Smith and College published in Developmental Cell came out to show that the amount of the ACE2 protein increases in the epithelial cells of smokers as compared to the non-smokers. So for example, here is looking at the human trachea, the tube that connects our throat down to the lungs, and it's showing that smokers here in red has a higher expression of the ACE2 receptor than non-smokers in blue. If we go down a little deeper into the lung, now at the large airway epithelium, the same story happens. Smokers in red have a higher expression of the ACE2 receptor than non-smoker. And if we even go further deep into the lung, to the small airway epithelium, now we see again that the smokers have a higher expression of that ACE2 protein than the non-smoker. So it seems that when we look at the effect of smoke, that cigarette smoke increases the amount of the receptor that is used by the virus. An interesting data that also was shown in this paper is that when they were looking at patients and taking patient samples, and they were able to divide those patients according to how many packs of cigarettes they smoke a year, and they organized them into 0 to 19, 20 to 39, 40 to 59, etc. They were able to show that the more packs of smoke that that person smoked a year, the higher the amount of ACE2 found in expression of the lung tissue sample from those patients. So it seems to be a correlation with the amount of the ACE2 protein to the number of packs that a cigarette smoker smokes a year. And therefore they concluded, as shown by this picture from the paper, that people that smoke are going to have a higher expression of that ACE2 receptor on the epithelial cells of the lung. So what is that going to do? Well, we hypothesize that if we now, shown here on the right, if we increase the number of ACE2 receptors on the surface of the cell, what we're doing is giving more viruses the capacity to infect the cell. So that could increase the viral binding of the coronavirus to the lung cells, and therefore the greater amount of infection. And that could correlate with further problems down the line in disease. So this is to be the hypothesis that we have, that the greater amount of ACE2 receptor may have detrimental effects and increase the infectivity of the coronavirus into the lung tissue. So now, is that actually having any impact on patients? And I'm going to show you two pieces of evidence from the literature. What I got here is a figure that I borrowed from a recent paper by Patanavanovich, excuse me, I butchered that name, and Glantz, that just came out in 2020, where they did a comprehensive analysis of many different papers, 19 of them, I believe, looking at different people that have COVID-19. And they were asked of everybody who got COVID, how many of them were smokers? Well, only about 218 people were identified as smokers. And that's one of the problems that we're having with this multi-data analysis, that not all the researchers are asking those questions when the patients are being taken into the clinics, or that information may be miscorrectly inputted in the system. But the interesting thing here, which I want to appreciate, I want to show to you, is that they found that people that smoke are almost twice as likely to have COVID disease progression compared to non-smokers. So that's interesting. Now, that was one paper. So I look at other ones and I found a similar kind of analysis by a different group. This is the paper from Zhao and its colleague that also came out looking at a different set of data. And they also found that there's almost a twofold increased risk of developing severe COVID-19 for people who smoke in comparison to those that don't. And I just found this morning a third paper that now states that it's about 2.5% higher increase. So there's a lot of evidence that is stating that smoking may have significant detrimental effect in the developing of COVID-19. So I will conclude with that to let my colleagues go, but I want to bring you to conclusions. Number one, the evidence tends to be there that cigarette smoke is increasing the amount of the receptor ACE2 in the lung tissue of people that smoke, and that could potentially increase the infectivity of the virus in non-smokers. And the second piece that I want you to bring to your attention is that it seems that by looking at this comprehensive data analysis from multiple peer-reviewed papers, that they seem to be a twice chance, a higher increase to receive, a progression to COVID-19 for smokers when compared to non-smokers. And that is all the information that I wanted to bring to your attention. I will stay here for questions for you later. And you can also find me at UC Merced as well as the NCPC website.
And thank you, Dr. Garcia-Ojeda. Excuse me, just want to introduce Dr. Lopez, who is going to talk, elucidate the understanding and addressing COVID-19, in particular misinformation among Latinx communities in California, Central Valley region.
Thank you. I don't think I have control of it yet.
Yeah, I think I am still controlling the screen. There you go. I don't have control anymore.
Okay. Yeah, my name is Gilberto Lopez. I am an assistant professor at the Arizona State University, but I'm also a research affiliate with NCPC. And I'll be talking a little bit about a series of interrelated projects that we're working on to try to understand how the Latinx community in the Central Valley understand COVID-19 and also the behaviors around COVID-19. So I'll talk a little bit about the projects that we're doing to try to understand, to try to gain knowledge of this. And then I'll end with something a little bit more applied. What do we do with this knowledge once we have it as academics, as researchers, to give it back to the community, in this case, to try to address the inequities that exist that are disproportionately affecting Latinx communities with COVID-19. So a very general overview here, that we know that COVID-19 is disproportionately affecting Latinx communities across the nation. And although there's these biological mechanisms, we kind of tend to look at the social determinants as the main drivers of why these inequities exist. This idea of where you work, where you live, and where you play kind of are factors into these disparities. Where you live, Latinx communities and other communities of color, people of color, are disproportionately living in crowded conditions, crowded housing, and also multi-generational housing. So you have these environments that are very ripe for the distribution of COVID-19 within cramped conditions. And where you work, you know, Latinx and also people of color are disproportionately part of this essential workforce. In this case, in the Central Valley, it's an agricultural region. And you have, for the most part, Latinx immigrants mainly working in agriculture. And these are jobs that are termed 3D, jobs that are dirty, dangerous, demanding. And the salaries, the wages are low, and the working conditions are subpar, substandard. And there's very limited PPE, personal protection equipment, and there's really no chance of people working from home. You have to be out in the field. And the idea of play, how does play, play, or where people recreate, or where people kind of have leisure time. Interesting thing in the Central Valley, there are small, small little communities. You go to any carniceria, any meat market, any store, compared to these big corporations, grocery stores, corporate grocery stores, the policies that exist in big grocery stores of how to shop, which direction to go, they don't exist in small carniceria, small corner stores or small stores in the little towns in the Central Valley. And that, again, leads to very crowded. You go on any Sunday or Saturday morning, you see very crowded conditions in these very small markets. And also the heat. The Central Valley, the last week has been almost every day over 100. So where do you go? You can't be outside. You know, this idea of it's okay to be outside in open spaces, but if it's 100-something degrees, it's impossible for some of these people in the communities to go out. So this is a social determinants, how they kind of factor into the unequal distribution of this. One thing that I'm focused on is misinformation. We know that us as public health communication individuals, we're doing a very bad job of bringing quality information, good information to the Latinx community about COVID-19. And at the same time, we see an increase in bad information or misinformation through a lot of the social media, especially WhatsApp and Facebook that are used, platforms used by immigrant communities a lot. And you see a lot of misinformation. So we're trying to do, so also to add to this, we know about the Latinx community in general. We have the data, how it's affecting it. We know very little of the different subgroups. Latinos or Latinx are 60 million in the US. That's, I believe, the second largest Latin American country in the Americas. That's a very big population. So we know very little of the subpopulations, subgroups, different immigrant generations, different immigrant groups, especially in the Central Valley. You have the non-Indigenous immigrants and then the Indigenous immigrants. And we don't know how this is affecting the two groups differently. Also within rural America, we know that there's a wave now hitting rural America, but we know very little of the different subgroups. How is it affecting the Latinos, the Latinx who work in rural America, which make up the majority of agricultural workers across the country? So one of the projects, it's a qualitative, we started with a qualitative study. We're trying to understand perceptions and beliefs and behaviors of COVID-19. So for this presentation, I'll talk a little bit about what we're doing with smokers and non-smokers. So we're interviewing, and we're almost done with these interviews, 40 Latinx across the Central Valley, men and women, and smokers and non-smokers to assess differences. Are there differences between the smokers and non-smokers in how they conceptualize and their behaviors around COVID-19? I'll share very briefly preliminary data that we have. One thing is that we're finding that it seems that smokers and non-smokers, and these are all Latinos, Latinx, they don't seem to have different views or different conceptualizations of what COVID-19 is, its risk, and its transmission. So that has implications, as we were seeing in the previous presentations, that we're pretty certain that smoking puts you at a higher risk of having more severe COVID-19 symptoms and the effects of COVID-19. However, if you have this community, this population doesn't perceive it, smokers and non-smokers don't see it as different. That has implications for how do we address it? How do we bring that message across to smokers in the Central Valley, to the message that yes, COVID-19 will disproportionately affect smokers, and how do we enact policies or campaigns? So that's one of the findings that we're still working on analyzing. The other one is with regards to information. It seems that across the board here in the interviews we've done so far, there's a lot of distrust of any official government sources of information. And it has to do a lot, you know, it's an immigrant community, and, you know, throughout the history of the US, we have policies that are actively trying to remove a lot of these communities across the country. So there's a lot of distrust of the government and what the government's telling you. The government's telling you to stay still, don't get out, don't leave your house, don't, you know, putting a lot of restrictions. So there's a lot of distrust on that. And those are preliminary studies. And we use some of this information to do a broader study and to try to get a more generalizable answers to these same questions of what are the beliefs and attitudes and what are the behaviors. But we're also trying to track here the socioeconomic effects related to COVID-19. So we're fielding, and this started this past week, an online survey. And our goal is to do this survey with 1,000 Latinos, Latinx across the catchment area, the NCPC catchment area. And in this case, we're trying to look at the indigenous immigrants and indigenous community in the Central Valley, specifically Mixtecos and Tiriquis who are in agriculture, and then the non-indigenous. We're trying to do half and half, as well as smokers and non-smokers, to see is COVID-19 affecting these different populations differently, and if so, to what extent? And the goal here is to do a follow-up survey. So we're doing one now. We're hoping to do it again in 12 months and again in 2 years. So we could trace what are the long-term effects. And it's predicted that we're gonna have these socioeconomic effects that are gonna linger for the next few years. We wanna see how it's affecting the Latinx community in the Central Valley, how it's affecting indigenous and non-indigenous communities differently. So that's what we're in the process of, and we're still rolling this out. Unfortunately, it's still too early. I don't have any data. So in a few months, we hope to have some data that try to answer some of these questions. And so just the last part here is addressing it. So what are we doing about it? So I'm gonna share a quick 1 minute, 1.5 minute video animation that we're working on. Me and other collaborators, we came up with CHAT, the COVID Health Animation Project. And it's a series of animations that are to address the misinformation in a culturally, linguistically tailored way, but also with sound, medical, and health information. So I'll share it real quick. Get my share.
I think you need to press play on it. Scroll the window up a little bit.
So all I see is the slide from the PowerPoint. But you know, if we're running out of time, I could forward this to everybody to see it. There's a link. We have a website for this. I'll forward the website in the chat so you can see it. So essentially what it is, just to end, it's we're starting to launch a series of animations that, in this case, we use Don Francisco, we use Shakira, we use J-Lo to bring the message, simple message, you know, stay 6 feet apart, wash your hands.
Lo hacemos, dice. Así, así, como baila la colita. Don Francisco. Me encanta esta canción. Pero la colita se debe quedar en casa. ¿Por qué motivo? Por el coronavirus. Déjenles explico. El COVID-19 es un nuevo coronavirus. Una familia de viruses que afectan el sistema respiratorio. El virus entra al cuerpo por los ojos, boca y nariz, y se extiende a los pulmones, y se multiplica rápidamente. El sistema inmune se activa para contrarrestar el virus. En la mayoría de los casos, el sistema inmune de las personas resiste y elimina el virus, y tendrán síntomas templados o incluso ningún síntoma. Pero personas de edad avanzada con condiciones médicas como diabetes, cáncer y problemas cardíacos son más propensas a enfermarse porque el virus causa daño a los pulmones. Algunas de las personas necesitarán un respirador artificial y algunas personas, desafortunadamente, fallecerán. Es por eso que debe evitar tocarse la cara con las manos.
O lávense las manos al tono de feliz cumpleaños. Feliz cumpleaños a ti. Y no sean como este muchacho que se la pasa visitando todo el mundo. Quédense en casa. ¡Let's get out!
And so just to conclude, what the reason I showed this video is, the goal is to, once we have more data, that way we know where the gaps exist in knowledge and in certain behaviors, in order to create more of these videos that are culturally sensitive, culturally attuned to the community we're trying to reach. And I believe, you know, as a researcher as well, I think that it's important for this information, not just to stay in the academy, not just to stay with policymakers, but to bring it to the community and put it to use to the community. And this is one way that, you know, through health communication is one way to do it. So I'll end there. My next slide, I believe I have all my information. If anybody has any questions, comments, also you can put them on the chat. I see some great ideas already. Thank you.
All right, thank you, Dr. Lopez, and that was wonderful. And hopefully it woke people up a little bit. Some of these talks can get a little dry. I want to now introduce or turn this over to Dr. Anna Epperson, who's going to bring some policy perspective here on our talk around tobacco use and perceptions of policy among adults in the Central Valley. So, Dr. Epperson.
All right, hopefully everybody can hear me. And I don't think I have control quite yet of the screen. There we go. Okay, thank you. I'm really excited. Actually, I'm gonna talk about some findings, our new findings from our research core at the NCPC. So very excited, sort of hot off the press. I wanna acknowledge my research team, the research core team, and my co-lead, Dr. Maria-Elena Gonzalez, who's in public health here at UC Merced, and also Dr. Bonnie Halpern-Felsher at Stanford School of Medicine. This is definitely a team effort. So as many of you have probably heard, there has been a lot less research focused on nicotine and cannabis in our San Joaquin Valley here in California. And so because of this, one of the primary aims of the research core has been to really assess nicotine and cannabis product use, and then to evaluate support for existing and emerging policy here in the San Joaquin Valley. And so because of this aim, we started last year with data collection of a large general survey of our area. And we were doing, you know, a general survey in the field, so in person, and we were also just starting to do a little online data collection. And then COVID-19 happened. And of course, as everybody knows, completely changed our world, completely changed everything. And so for us, particularly in the research core, we had to completely end in-person research and had to go fully online. So while that was a big pivot for us in terms of the sort of the aims and the research goals we had, it also gave us kind of a neat opportunity to sort of look at data we had collected online prior to our mandatory stay-at-home order here in California, which was on March 19th. And then also to look at data we had collected after in this community and to sort of see what that might say. So I'm going to basically present very briefly some initial findings from two studies today. First, survey one, which is that general survey I was just telling you about. where we're sort of, our aim is to look at nicotine and cannabis use and perceptions about policy. We've had data collection for the last year in person, obviously, but primarily for this purposes of this presentation, I'm going to focus on the online data from participants in February 2020 and May 2020. And then the second survey was led by our graduate student researcher. Her name's Deanna Halliday. And this is a smaller pilot study where just last month we collected data on smokers and asked them about their COVID-19 perceptions and how that might impact their tobacco and cannabis use. People had to be adults. They had to live in our catchment area. That's these 11 counties, and this is a map of California, and the highlighted brown is our 11 county area. And we basically conducted this completely online, and everybody was recruited via Facebook, and they obviously had to be in these counties, and they were compensated for their time. So going first to the first survey, we are looking here at two graphs, one February, May on the right. And you can see here that we did see a difference in e-cigarette use and marijuana use in the May sample versus February. Specifically, we saw that e-cigarette use was slightly lower in the May sample and marijuana use slightly higher compared to February, but no difference in the cigarettes. Cigarettes denoted by dark green, e-cigarettes by orange and gray for marijuana use. When we ran regression analyses, allowing us to control for basic participant characteristics, so that's things like age, gender, level of education, income, we still found that this remained, this effect, where people in the May sample were less likely to use e-cigarettes, but more likely to use cannabis or marijuana. We also looked at intentions to quit among cigarette smokers and among current e-cig users. So specifically, we found, again, we ran regression analyses, we controlled for those characteristic demographics I was just telling you about, and we found that participants surveyed in May, and these are current cigarette smokers, had a higher odds of intending to quit smoking in the next 6 months compared to those current smokers in February. We also found that current e-cigarette users were more likely to report intentions to quit as well in the future compared to current e-cigarette users in February. Turning now to survey number 2, which, as a reminder, is this smaller pilot group of all current cigarette smokers, and we're asking them about their COVID-19 perceptions and how it might impact their tobacco and cannabis use. And we found that about just under 40% were reporting that they had tried to quit in the past 3 months. And if you remember, this is June that they're reporting, and mandatory shelter in place in March. So assuming that they had this unsuccessful past quit attempt during sometime in that shelter in place or after the state started opening, but sometime between now and then. We also saw that about 1/3 said that they intended to quit in the next 30 days. So when we look at whether or not there's an association between these quit attempts and quit intentions and COVID-19 perceptions, we actually found that in analyses where we controlled for these characteristics again, but this time we also added in number of cigarettes per day for each participant because these are all smokers, we found that increased worry that their cigarette smoking would make them more susceptible to COVID-19. And this is worry with a reason, as we heard from Marcos's presentation, meant that they were more likely to have unsuccessfully attempted to quit in the past month. And if you were more worried, you were also more likely to intend to quit in the next 30 days. We did ask people if they had any trouble accessing cessation aids or products during this pandemic. And surprisingly to me, over 75% said yes, they did have some difficulty with, almost 40% saying moderate to very, which is kind of a shame. We also did ask these smokers about their marijuana use, and this is past month marijuana use, but about 40% did report marijuana use. And when we looked at this worry and concern about catching COVID again, we found that in analyses that those who were worried were more likely to have used marijuana in the past month. So, some conclusions. First was that you do see that in study 1 specifically, we see that there does seem to be a difference post-mandatory shelter in place in the sample in terms of e-cigarette and marijuana use, but no real difference in cigarette smoking, I should say. We did see that among current cigarette smokers and current e-cig users, or vapors, as we sometimes refer to them, that there was this difference in intentions to quit, higher intentions to quit in the May sample compared to February. In the second study, we found that concern about COVID-19, justified concern, was related to quit attempts and intentions to quit in the next 30 days. And that this concern about COVID is also related to increased marijuana use. So, okay, there are some limitations. There are always limitations with studies and data, but I think that there are some real implications for our region from these findings, at least preliminary implications. First, I'm not sure that e-cigarette use is necessarily going down, so maybe I shouldn't have phrased it that way, but I can say that e-cigarette use has really been a huge concern in our region, as it has been nationally and in the state of California. But with EVALI last year and all the concerns I was hearing in the field then, and now with COVID-19, I'm hoping that, dare I hope, that maybe e-cigarette popularity is going down. So that's one hope. We are seeing increased marijuana use. Recreational marijuana is now legal in California as of the last couple of years, as most of you are from California, obviously know. And so we probably were seeing an increase anyway, but it's also that we're having a COVID-19 pandemic. It's stressful. There's a huge economic fallout, and that's really hitting our region hard. So there's possibly a time for us to be seeing increased marijuana because of all these things, but maybe it's our job as health practitioners to be communicating how to use marijuana, the risks, the safety, et cetera. We're still seeing a cigarette smoking disparity. Cigarette smoking is already higher in the Central Valley compared to the rest of the state and compared to the national numbers. So there's sort of a time for us with this interest in quitting that we're seeing preliminarily in these data, that maybe this is an opportunity to ramp up cessation efforts, even though we've got a lot on our plate right now, I know. But also to maybe find new ways for us to increase access to cessation aids and products, because this is sort of, striking while the iron is hot. So I think that's going to be something that I'm going to definitely be making my priority for the next 6 months. So that's pretty much it. Thank you. And here's my contact information.
All right. Thank you, Dr. Epperson. And thank you to all our speakers today. I think I have us about 6 minutes behind schedule, which isn't bad. So I think we're going to move forward and take some questions now. Our panelists can respond as they want. And if you have questions for our speakers, please go ahead and put those in the chat box. Some folks did submit things earlier during the registration process, so we will work our way through those. And Nancy, is there anything special you want to do?
No, I just wanted to mention that thank you to all of our presenters. Those were really fascinating and wonderful presentations. And I want to let everyone know that the presentations and video of this entire webinar will be available on our website. So should you want to refer back to the presentations in the future. And Norval, if we want to take some questions that have been posed in the chat and maybe tack back and forth with
Sure.
Submitted previously.
Yeah, let's do that. So if I go to the top of them, I see that there is a comment or recommendation for the animations, a lot of praise for the animation, which is great. They're great. To include Walter Mercado as a possible someone to have or represented maybe in those
Yeah,
animations?
That's
yeah,
great.
comments. I think that's a really good idea, and we'll look into that. So right now, what we're doing, we're trying to get. So these are pretty expensive to do these animations. It's 1.5 minutes. I had no idea how pricey they are, so we're applying to grants. We're hoping to get grants to do more of these. The Walter Mercado, I love that idea. It's a really good idea. Someone's mentioning Selena. There's copyright things that we need to get through, but yeah, no, but I think these are great ideas, and thank you all for suggestions.
Thank you. I see a question here. Do vapors refer to e-cigarette products and not marijuana vaping products? Any data or insight on the use of marijuana vaping products during COVID-19? Marijuana vaping products. And I know, Anna, with your talk that came up too around, was marijuana, was it vaping or smoked or both?
Okay, so marijuana use was all of the above, vaped, smoked, edible, topical. We did see that about half of the sample was reporting that they were using it in a smoked fashion, and then we got a little bit, nice breakdown of 25% vaped, 25% or a little bit less than 25% topical, and then a very small amount of edibles. So I haven't broken it down in terms of which one, but when I am talking about e-cigarettes, I'm talking about vapes, electronic cigarettes. But I didn't necessarily break out the marijuana data that way. But it's a good suggestion. That's the next step, is to go and look at precisely which subgroups of marijuana users are maybe most at risk.
Yep, good point. Another question, and I think this was in the registration questions too. Any difference in working with cigarette smokers and people who vape in a quit program? What data can I use to educate my city council to pass a TRL, tobacco retail license?
I don't know. Norval, I feel like he'd be just as good at answering this question as me.
Right. Yeah, I mean, I think at this time, given EVALI and the situation that we saw last year with young folks, I think that it's hard to say, we're going to be lighter on people who are vaping versus smoking. I think it's how you're irritating the respiratory system or the airways that really is the point here. And that, as we saw in the presentations, especially the first one, I thought was excellent in that, if you get those ACE2 inhibitors up, if you're already from smoke going to see some of these things, we're seeing some of this from vaping as well. The UCSF paper looking at a similar increased risk of severe COVID cases with people vaping or e-cigarette use, electronic cigarette use, and I think that was nicotine use and combustible smoking. So yeah, we're kind of treating smoke and vape, if you're getting into the lungs and it's irritating it or potential irritant, we have to really be careful around that. So I wouldn't tell vapors that you're off the hook. I don't think that we want to do that. Now, in terms of city council folks, that one is to have a policy informed, evidence informed discussion around policy, and it is important to work with your either scientists or public health people around that. I feel like there is a lot there. It's just, where is it all compiled on the latest and greatest around vaping, and what it's doing to your health. But with the EVALI cases, I think it's going to be harder now to tease those out because there's so much coronavirus and other respiratory pneumonia that's going to come up. I think we're going to lose the EVALI contribution to all of this from vaping.
So
And if I could just,
there's a related question about whether EVALI is still being reported in young adults and teens.
I believe it is. My understanding from a physician who knows a little more about this is that it is not, we have a higher chance of confounding right now. So EVALI's not, we're likely still seeing it, but it's not going to be the first thing diagnosed or assessed. Like we talked earlier, if you're not asking people when they come in for COVID testing, if they're smoking or vaping, you're not going to have that data, right? So I think that's it's tough to have a data-driven discussion around that, as well as underreporting of there are folks who are not getting tested that have COVID, and it's not, you know, so there's some underreporting there. Especially think of some of the communities we're talking about, how likely they are to feel comfortable to get tested, you know, access issues. So yeah, I mean, I think that is tough. But is it being recorded? I think CDC is still doing it. I just think it's so down below that we're not going to really have good data right now. But that's more my opinion. If anyone else has thoughts on that, please chime in.
So
Okay.
another question was, any data or insight on the use of marijuana vaping products during COVID-19? I think, Anna, you spoke a little bit about this, about potential upticks due to stress and other related issues.
Yes, a little bit. So it does look like we are seeing increased use. Now, is it that we're seeing increased vaping or smoking it? I will say that really people were afraid after Valle, and that was happening, you know, last year. And people were really, really afraid in the Central Valley because people within each county were hearing about somebody die. And so, you know, that would be like the news that was, you know, the moment. So when we were out in the field, I got at least half of the questions I got were about Valle and how do we make sure that, you know, my family member or I don't use the wrong product. So I think that vaping marijuana is still occurring, but I don't necessarily think that it's as popular as it used to be. I think a lot of people went back to edibles and to smoking marijuana in a combustible fashion, like the traditional joint. But I can also say that, you know, that's a very interesting question. We also don't have as many dispensaries here in the Central Valley. We're getting more every day. I think that there are more illegal dispensaries here versus legal. So this is kind of a hard thing for us to track in this 11 county area. But it is a good question, and it's something we need to find out more about.
And I think, Anna, if you saw that increase in marijuana use, there's probably, like you said, a combo effect of, there's probably a vaping contributed in that 20-something%, 26% rate that you saw. I don't think it's just all combustible, but it is hard to tease that out, how much is actually vaping. There was a question presented around someone who does in Stanislaus County teaches a quit smoking class and how to, you know, whether we want to treat vaping differently than stop smoking. Again, this comes up because people who vape think that it is healthier. So I think the California Department of Public Health has some good stuff around, the issues around vaping, the dangers, the health risks, what you are, even if we don't know cancer, the contribution to cancer, there's some good evidence around cardiovascular, heart related, blood pressure. And then as well as we're talking about all this irritation, increasing mucus, increasing epithelial function, of those cells. And that's, you're compromising it. That I think the message is we want to get across, if you want to create yourself so you're as healthy as possible. So in the case, unfortunately, if you do get COVID, your body has the best chance of fighting it off. And I think that is, there are different ways to craft that message.
And can I just chime in? I haven't done any work. I'm sorry to say, guys, I haven't done any work with adults in terms of vaping, the difference between vaping and cigarette smoking cessation. Most of my adult work has been all cigarettes. But what I have found in the last year, and she's part of our research core, Bonnie Halpern-Felsher, I've been doing some work with her about youth. And all signs seem to point to vaping cessation and cigarette cessation being different. And I think one of the biggest reasons that they're going to be different is that people can often vape way more nicotine than they actually smoke. So,
right.
You've got this typical half a pack to a pack a day of cigarettes smoker, but you'll see people vape a pod or two, and that can be more than a pack. That can be several packs. So it's sort of saying that people that are vapers are potentially going to need stronger nicotine replacement therapy, and that there's just going to be a whole host of behaviors that are going to need to be addressed that are completely different than the behaviors with cessation. But I can say that, there's a lot of talk around the table with, MDs and psychiatrists, and a lot of people are baffled. They're kind of still trying to figure out, how do we take what we know, what's good, in our smoking cessation for cigarettes, and how do we make sure that we're not just using the same stuff, but that it's also going to be effective for vapors and the new stuff, adding it in. So I wish I had more, but there is a tobacco toolkit, and it does include vaping stuff and a cannabis toolkit at Stanford. It's all free if you want to look that up for youth, but applicable to adults.
Thank you, Anna. So this question might be for Dr. Garcia-Ojeda. It's on the web that nicotine has anti-inflammatory properties and reduces severe COVID-19 symptoms. Is this true?
Thank you, Nancy. That is actually an excellent question, because that is a hypothesis that has been floating around online based on a couple of studies, one of them coming from France and another one coming from Greece, where they are basically saying, well, we see less patients who smoke having COVID-19, so most likely nicotine has a beneficial effect. But let's divide that into two things. Nicotine as a beneficial effect is not the same thing as smoking as a beneficial effect, because nicotine is a component of cigarette smoke, but so are a lot of other compounds which are very damaging for the lung tissue. So that's one thing. So we have not done yet the experiment to determine, for example, if somebody wearing a nicotine patch may have an amelioration of symptoms. So I would be very careful when you're looking at those studies coming out. The other thing about some of those studies is that they're not published yet in peer-reviewed journals. They have been put outside in some of the new online available repositories so people can see the data, get excited about it. But once they go through the peer review mechanism, some of them do not pass. So they do not get to the point in which the scientific community said this data is solid and therefore we can move forward by saying this claim. So those two things. One thing, nicotine might be beneficial, but how do you get that nicotine in place to do the actual benefit? Definitely smoking cigarettes is not the way to go about it, because of the well-established problems that we know that smoke can have on lung tissue. And the other is like, just be careful of how some of those coming from the web, that information is still vetted, because oftentimes it is not vetted yet through the rigorous peer review process that science goes through.
Thank you. And that sounds like something, Gilberto, you're thinking about really how do we get clear evidence-based information out there, rather than the misinformation that we all have so much access to. So
Nancy, I just want to mention, so I got a comment here, and also in other places where I presented these videos about representation. So how do we, who are we giving voice to, and how do we select who we're giving voice to in these videos and these animations? I think that's important thing to consider. In this case, we have Don Francisco, Shakira, and J-Lo, and we have a man who's a physician. And what is that, what's the underlying message behind that? And I think that's a good conversation to have, and we had that conversation with our production team. We understand Don Francisco is a problematic figure. He's been a problematic figure to some extent, to a large extent. But at the same time, we're trying to, how do we weigh that with trying to bring in a character that we believe almost every Latino in the US knows who Don Francisco is. Every Latino in the US knows what that song is. So we're trying to bring that and bring the messaging of, the purpose of this to bring a message, and then with characters that everyone understands. So it's important to understand, to be aware of and to acknowledge that who we're giving voice to has these underlying kind of implications of our society, the way we objectify women, the way we give voice to men over women. So in the series of animations, the next series of animations, we're switching the characters as much as we can. But at the same time, I think the ultimate goal here is to make sure that the audience takes away the message from COVID-19 as much as possible. So I share the concern as well. We've discussed these things of who are we representing and who are we giving voice to. So I just wanted to mention that because it is an important thing to consider when creating more of these animations.
All right. Do you think we're at time to go into breakouts?
Yes, I think so.
Okay, so thank you for that also rich discussion. And as you can see, there are a lot of questions. There still are, much research is needed in these areas. So for folks who want to stay around and participate, we'd like to hear from you and what you're experiencing. So Zoom, I think, is going to randomly put people into rooms, and we'll spend about 15 minutes discussing what you're seeing in the community, what you like to share in terms of challenges and successes and possible next steps. We prepared a few questions to help guide it, but we're open to others. So